I'm just going to introduce myself, a little bit about my background. So I was born to two Mexican parents who immigrated here in the late 70s. And some would say it was an illegal cross to the border. But when Ronald Reagan was president, he believed in the idea of amnesty and for getting people legal residency, even if they may have got here illegally. And so in that year, they were able to become legal residents. And so that's my mom and I. And so she came here and worked in the factory from the ages of 23 up to retirement. We currently live together. And my dad, he decided to leave a few years ago. So it's just my mom and I, but that's okay. And so I decided to go into the sciences. I decided to pursue a bachelor's in microbiology, and then later a master's in biomedical science, and then another master's in public health. And so that's my graduating class and I. That's me in the corner. All right, so that leads me into, let's see if I can. All right, so that leads me into 1 year ago. So 1 year ago, I had this mysterious lump appear in my armpit. And then after that, they appeared in my neck. And so when I went to the ER, because I worried myself, I started looking up a bunch of stuff on Google. So I went to the ER. And by the time the doctor had gone to see me, the swelling had gone down. And so he didn't know what it was. And he said, "I don't know what you have." And so I was very embarrassed. And I walked out very angry, but I was angry at myself. And I told myself that I would never go back to the hospital for something so simple again. But that was a mistake because a year later, when I had got this rash right here, I didn't want to go until it was too late. So there's another picture there from a recent ICU trip. And so overall, Still's disease, it's a challenge to diagnose. A lot of patients come in with high fevers. They're very ill. And so Dr. Kush, who's one of my favorite rheumatologists, he actually saw one of his first cases in 1984. And when I had came into the ER for the first time during the onset, the ER physician, he opened the door and he looked me in the eyes and he said, "You are not an easy case." But it was all in lighthearted spirit. And now that I think back, it's pretty funny, actually. So here's Dr. Kush, and he's the author of Room Now. Here's a pop quiz question, but don't worry, you don't have to answer it. But the question asks, adult onset Still's disease is a diagnosis that you can confirm with a test. So is it true? Is it false? And the answer is false. So there is no confirmatory test. There is no diagnostic test to confirm it. And so Still's disease is a systemic inflammatory disorder. There's no etiology, there's no diagnostic test. The pathology is not well understood. And so it's a syndrome. It's based on the criteria of exclusion. And the onset is usually from around kids to the age of around 35 or 40. And so there's quotidian fevers daily, meaning they spike once or twice a day. There's the prodromal sore throat. So prodromal meaning it happens at the onset. And then there's a rash there that I got, the evanescent rash, and that's that appeared in the higher glute area. And then after the systemic the onset, you get the chronic inflammatory arthritis. And so the disease bears the name of George F. Still, who in 1897 he described 22 children who had chronic arthritis. And then a subset of those 22 children showed anemia, they had weight loss, and then they had enlarged lymph nodes. So much like the ones that I had when I had first started. Okay, and so during this time in 1897, they didn't yet describe the high fevers. They didn't mention the rash. And the rash wasn't actually mentioned until 1933 by a paper of Mulkey, or Boldero actually, who described the Still's rash. And then in that same year, Mulkey, who was of the Scandinavian literature, he described Still's disease in adults because it was first seen in children. And so the French literature also called it the Whistler-Fanconi syndrome or subsepsis hyperallergica. So it has all kinds of names. Okay, so here's one of the first papers by Eric Bywaters. And then here's another paper by Joseph Bujak, who's from the NIH. And so Dr. Cush suggests that these two papers are all we really need to know if we want to understand Still's disease. But he does mention that they're highly descriptive case reports. They're up to 18 pages long. But these two papers really gave way to the understanding that females and males are equally affected. And AOSD really is just a continuum of the juvenile disorder, but it's much less common in adults, but it behaves the same way. And so here, Dr. Cush also points out that mistakes that he often sees done. And so that would be making a diagnosis based on an undiagnosed fever, on only some systemic manifestations, but you actually have to have the triad. And so as we see here from the Bywaters and Bujak paper, we have fever, the evanescent rash, and the chronic polyarthritis. And so the fever in the Bywaters report is spiky, it shoots up and down, it returns to baseline. And so this is happening every single day, and that's the definition of the quotidian fever. And so it occurs about 0.16 to 4 cases in the population of about 100,000 to 1 million. A major medical center will only see 1 or 2 cases per year because they often end up in different places and unfortunately not in the right hands until it's too late. And so really from this graph, all you need to know is that the red represents males and the orange represents the females. And so we can see here that both sexes are equally affected. And the age of onset is usually in the 20s and the 30s, and very few cases after the 40s. And so for myself, I land about right here in the middle. My onset was right before my 28th birthday, and so I would land right in that average. All right, so we go back to the Still's disease triad. So we have those daily fevers every day. They have to spike above 102, and then the evanescent rash, where there's a picture that I was able to get of the rash appearing on my legs. And then finally, the polyarthritis. It can happen, it looks like rheumatoid. It happens in small joints and large joints. It can be symmetric. It can be progressive, and it will stay progressive in some set of patients. All right, so the fever is the first of the triad. And it rises above 102. It then returns to baseline, as we see here. And so I waited days 3, days 4, days 5. After day 6, I knew something was wrong. I knew that it wasn't supposed to happen that way. And so the peculiar thing about this condition is that it happens at the same time every day, and it starts with these violent shaking chills. And so I remember my teeth would start to chatter even when I had the heater on full blast. But eventually when it's over, you start to sweat a lot, and that's when you lose a lot of the electrolytes. But by morning, everything is better. So let's say a provider would come in to see the patient during morning rounds. They would look normal because they won't look as sick as they did last night. And so after steroids are introduced, the fever will go from spiking twice daily to once daily. And then it's usually never in the morning. Dr. Cush notes that if it is in the morning, it's probably an infection or a malignancy, but it's not usually Still's disease. And here is the picture that I was taken at the hospital during the onset. All right, so now we go over to the Still's rash. It's also called the rheumatoid rash. It happens really when the fever starts to spike. So it's evanescent, it's salmon pink in color, and it's called various names throughout the literature, but it does change every day, and it's most likely to appear during the febrile time points, so during when the patient is most sick. And it's erythematous, it's faint pink. It can have macules, it can have papules, but overall it looks like a viral morbilliform rash. It doesn't like to come out on the face, on the palms, or the foot soles. There's another picture of it during the onset. and it comes and goes. Here's another picture of it. This one came out, the one on the right came out when I was working on the presentation last week, actually. So they're quite random. All right, so we can see the Kepner phenomenon here, which is when if you scratch yourself, the rash will appear along those lines. And so this is a picture that I took during the onset. And then this is another picture in another case report. So these are the features of dermatographism. And the Kepner phenomenon can be seen when the patient scratches, for example. The rash will form as isomorphic lesions along the lines of former trauma. And Kepnerization, so if you take the pen and you scratch it on the skin, you're going to get a wheal and flare. And so that takes about an hour to go away. And then urticaria and pruritus, which is the hives and the itching, that can be really intense. But it's also a common feature that we see among the autoinflammatory syndromes. And moving forward, here's another question. So which is true about joints in AOSD? And I'm going to go over each one of these. So A, oligoarthritis is more common than polyarthritis. So if Dr. Krish says that if a provider sees oligoarthritis, then they should probably question the diagnosis. B, 10% have sacroiliitis. Sacroiliitis is not part of the condition, so it can't be B. And then C, seropositivity leads to erosive arthritis. So this is a trick question because seropositivity is not part of the condition by definition. So it can't be C. C is false. And so that leads us to E. 50% will develop carpal ankylosis during the course. All right, so for some common features, they will be myalgias, which is muscle pain, arthralgias, joint pain, and they should evolve into arthritis within the first 3 months. It will usually be a polyarthritis. And now over here on the diagram on the right, so the number 18 shows that in the case report, there were 18 wrist involvements. And then where it says the 14, there were 14 wrist involvements and then 11 for the shoulder. And then over on the right side, so after 6 months of the disease course, we dropped from 18 cases with wrist involvement over to 15 cases. And then from 14 cases with elbow involvement, they go down to 4. And then 11 previously went down to 5. And so it tends to stay there in the wrists, in the knees, and in the shoulders. All right, so we remember from the quiz question before, half will develop intercarpal ankylosis. And so what that means is when the capitate right here fuses to the hamitate over here, and then to the second and third metacarpal spaces, and then this bone here will also fuse to this lunate bone over here. And I'll show you what that looks like. Okay. So there's a patient here who in August of 1972 had only wrist pain and some swelling. But then a few months later, in March of 1973, you can see how his carpal right here fused to those metacarpal spaces here and fused to that lunate down there. It's quite typical, but it doesn't usually happen as aggressively as it did in this patient. And some common features that we can see, about 2/3 of patients will have a sore throat. And then here over on this side, we can see the general features such as the high fevers, those lymph nodes, the muscle pain. And so what are some lab abnormalities that we can see? Usually the labs are as distinctive as the clinical features. Everything should be seronegative by definition. There will be high white counts. The hemoglobin and the hematocrit will drop dramatically. There will be very high saturates, and platelets will be especially high during the acute phase response. Albumin will drop in response to IL-1 and IL-6, and then anemia will become more prominent. So there's going to be a lot of weight loss. So the albumin, the weight loss, and then the anemia, they all parallel each other in patients who are actively systemic. And then surprisingly, what surprised me was that the ferritin is only seen in 50% of patients. So Dr. Krish notes that if a provider relies heavily on ferritin, it's a big mistake. But in general, the ESR, the CRP, and platelets are all up. And so from here, what we really just need to know is that as the disease patterns go, so everyone will start out systemically. So as we see here in red, that will be the fever, the crazy looking labs. So on the first box, we have the monocyclic pattern. And in some people, the disease will go away and it will never come back. So, but that's just 1/3 of the patients. And so in the second scenario, we have the polysystemic cyclic pattern. And so we'll have disease-free intervals in between those systemic episodes. And then down here at the bottom, we have these two graphs. We have the monosystemic and the polysystemic with chronic inflammatory arthritis that looks like RA, and that's indicated in the blue color. So that will always follow the systemic manifestations. Okay, so as for mortality in AOSD, we can have DIC, as we see here in this in the legs here, and it happens because something goes wrong in the clotting process. Other reasons usually for mortality are steroid therapy complications, where patient will get an opportunistic infection, or MAS, which is macrophage activation syndrome. So that's quite serious. And if it does happen, it has to be treated as soon as it's suspected. Okay, and so now I want to jump over to how on June 27th, I attended a Dragon Talks, and then a few hours later into the morning, I ended up at the ICU. And that happened because in my region, it ends, the Dragon Talks ends at 6 p.m. And then after that, I went for a walk with my mom. We came back, and then I felt the violent chills. I took my temperature, it was about 102, but I still didn't want to go to the hospital. And my mom insisted that we go, so I listened and we went. And by the few hours in the morning, I was admitted into the ICU, and this is a no, actually, from the doctor. And so she typed up, Daylene Cortez presented in critical condition requiring constant attention. While immediately available to the patient, I have reviewed notes, charts, labs, emergency department data, and imaging studies. I have also performed serial assessments and spoke to a family member, which was my mom, and consulted on this critical patient with hypotension requiring aggressive resuscitation who has the potential for high morbidity mortality. I spent a total of 65 minutes throughout the day delivering critical care to this patient exclusive of procedures. So that was a quite scary night. The doctor did speak to my mom. She did tell her if we had family members who could come, just because things weren't looking too good at some point throughout the night. And so here's another note where she said patient was now hypotensive. So my blood pressure had dropped to the 71s, 40s, level fed was ordered. And then so she paged the surgery on duty. He said he didn't see any gallstones, but he was able to see gallbladder thickening. They weren't sure if that was the main process. It was actually Still's disease. And so now here they did a CT scan to see the organs inside. And so the radiologist said that he found mild distal stomach wall edema can correlate for gastritis. They rolled out gastritis. And then periportal edema, which can be seen with aggressive hydration, because I did get fluid overloaded. And then here was just, there was possible left atrial enlargement. And so that was from an EKG done at the onset. And so really here is just, I highlighted something I thought was interesting. There's prominent segment of small bowel with wall thickening in the upper left quadrant, which can represent focal ileus or enteritis. And then the hypotension, they thought it was a suspect due to a flare of Still's disease versus adrenal insufficiency. But now, when I went to follow up with my rheumatologist, she said it was actually both. So it was the adrenal crisis and the Still's disease. And this is just a summary of what they found during my visit in June. So they saw the pericholecystic fluid, periportal edema, the focal ileus enteritis, and the distal gastric wall thickening. And then there was some mild perihilar pulmonary congestion. And then back in May, during the onset, they did see some mild increase in opacity in the lungs, so suggesting of bilateral interstitial infiltrate in both lower lungs. And so here's just, they wrote down that I had juvenile arthritis at the age of 12. And then as for the heart issue, cardiology felt that elevated troponin was likely secondary to cardiac or pericardial inflammation from Still's disease. And so those elevated troponins and was felt to be related, as they said here, to the inflammatory process from Still's disease. And it does get to your heart. It's pretty common to see that happen. And then last one. So here was just from my onset in May. And so there we can see the triad here with the fevers, the rash, and the arthritis. They needed to see it for more than 2 weeks, but it's there. And then the elevated ferritin, the ESR, the CRP. All right. So what a rheumatologist will use is the Yamaguchi criteria. So it's often talked about, and here you have to get 5 or more points from the major list, or actually in total, but 2 features have to come from the major list. And then there's no limit on how many for the minor. All right, so as for assessing disease activity, you can watch closely or your providers can watch closely the SED-rate, the CRP, and that will tell you how active the patient is. But if, and then you just treat somebody would just treat it like RA. But if someone has a systemic disease, then Dr. Cush notes that what he would do is he would take the simple stuff like the ESR, the CRP, the ferritin, and that will come out, that would work just as well. And then you could take the NLR ratio, which would be the neutrophil to lymphocyte ratio. And so if that's more than 5, then the patient is at risk for MAS. And then aldolase, it's a useful biomarker. And in patients who have Still's disease, the systemic juvenile arthritis, these will be very high. And then the myeloid-related protein, so that's been seen in some reports to be very good, but it's too early at this time to know. And then for inflammasome activity, microarrays will improve. They will fade with improvement, and they will disappear with true remission. And then here from this graph, all we need to know is that the NLR up here is highly predictive, especially when compared against CRP, the ESR, and the ferritin. All right, so how do we treat it? All right, so the treatment paradigm, everyone is going to start out on high-dose steroids, 60 milligrams a day. And Dr. Cush does suggest not for providers not to prescribe 5, 10, 15, or 20 because it's not going to work in the case of the onset. And so it's rare to start out with 40 milligrams, but if a lower dose is used, then it's recommended to combine it with methotrexate or an IL-1 or IL-6 inhibitor. And if IL-1 is given, then it's best to take it at night because IL-1 and IL-6 are circadian cytokines. And so they come up late at night when the fever and Still's disease loves to come up. IL-6 is a little slower to start, but it will work just as well. And maybe even better in patients who have arthritis that's really problematic. And as far as the management, when a patient is transferring from the systemic disease to the articular disease, then it's treated the same as RA. And so there's methotrexate, TNF inhibitors, combo DMARDs, they all work as well. But the challenge really is treating macrophage activation syndrome. And so it's down here in the pink. And I'm actually going to hand this over to the YouTube video, just a couple-minute video of Dr. Cush talking about MAS and Still's disease.
The cytokine storm is the same as, and a cytokine storm being infamous during COVID, is the same as macrophage activation. It's the same as HLH. All these patients have sudden high fever, hypotension, CNS manifestations. They take a turn for the worse. And it's exemplified by extreme levels of ferritin and rapidly rising LFTs, AST and ALT more so than ALK-Phos. They develop a pancytopenia. So when they once had a high platelet count and a high white count, they are taking a turn for the worse and they're bottoming out if you don't catch them soon enough. It has all the same biomarkers as does cytokine syndrome. I want to tell you that, again, the hairs on the back of your neck should stand up when you see a patient whose SED rate is dropping when it was once high, whose white count was dropping when it was once high. And now the CRP and the ferritin are going even higher. This is macrophage activation. The earlier you make the diagnosis and intervene, even if it's not complete, and there are criteria for this that I don't think are worth your looking up, you should treat if you suspect. By the way, hemophagocytosis on bone marrow is not required for the diagnosis. If this occurs in kids, the mortality here goes up to 20%. In adults, the mortality here has been as high as 38%. What do? You start them on high-dose steroids, very high-dose steroids, 2 milligrams per kilogram, split doses. Start them on an IL-1 or an IL-6 inhibitor. And if you have access to something to inhibit T-cell activity and all these cytokines that are being generation, emapalumab or cyclosporin is what I prefer. The etiology of this is shown on the right. NK cells and dendritic cells, under the right circumstances, now are activating CD8 cells, and you have tons of cytokines being produced. The main one that drives the syndrome is gamma interferon. Emapalumab is a gamma interferon monoclonal antibody therapy that works incredibly well. But by targeting T cells with cyclosporin or etoposide, you're cutting down on the plethora of cytokines that are driving MAS. Let's summarize. Stills in kids and adults are the same. It is important that you confirm the diagnosis by finding the triad and looking for the other suggested features. Know the criteria. If you don't know the criteria, know the website, stillsnow.com, and that'll teach you how to make the diagnosis. If they're atypical, at all atypical, then you really have to question the diagnosis. If they don't meet criteria, question the diagnosis, and then start to do gene testing. You know, if you live where FMF is prevalent, test for FMF. And again, you can make the diagnosis there on the number of days of fever. You know, something like FMF or some of the CAP syndromes will have a few days of fever, right? Whereas something like TRAPS will have 10 days to 20 days of fever, and then it will go away. But gene testing is important. You have to consider, besides autoinflammatory conditions, infection, leukemia, lymphoma, and that's, I think, takes care of most of the cases that get confused with Still's disease. Worry about MAS, use IL-1 and IL-6 inhibitors liberally, and tell your patients this is not something that goes away in a few weeks. 8 months to 8 years, and luckily, some will go into long-term remission. Hope you found this valuable. If we don't get to do questions here, I'd be happy to take your questions by email at jackcush@roomnow.com.
All right, so he's actually one of my favorites. He has his podcast called Room Now. The video was for providers, but as a patient, I think it's really interesting. All right, so that takes me on to Still's Disease Awareness Day. So over at the AI Arthritis Foundation, we are hosting an awareness day on September 7th. And so we are putting together posters, and we're running a social media campaign so that people can see what Still's disease looks like physically. And so here's another picture that I submitted. And these are some of the prompts that other people can use so that for what they would want the world to know. Some prompts are, I will not stand still on September 7th because, and then my Still's disease looks like. And so here's another graphic for the social media campaign. And then here are some photos that I had submitted. Eileen, who spoke with us pretty recently, actually created this poster out of the photos that I sent to her. And so we're also going to host a, so I volunteer for them, and we're going to host a Still's disease webinar on September 7th. And I'm going to put in the attendance link in chat down below afterward, but even if you can't make it to the event, you can still register, and then you'll get the recording link if you're not able to attend the event live. And so now that leads me to the end of the presentation, and I wanted to make a tribute for those who are no longer with us. So Tammy is a mother who, unfortunately, she lost her son to the battle of Still's disease. And so his name was Ronnie, so he's right there. Looks like he's in the hospital, and it's just, I'm sure we all know what that feels like. And here's another picture of him. It's quite touching. But I wanted to take these seconds to hold the tribute to remember those who are no longer with us, who have parted from this earth, because grief is an emotion that makes us human, and it connects us as human beings on a deeper level. And then we have this letter from Melly, who was one of the founders for the Still's Disease Foundation, and she's also no longer here. The original founder also lost his battle to the disease, and so sad, but it's just grief. It's what makes us human. So that we have there, that leads me to the transition of gratitude. And so what is one thing that you're grateful for today? I think gratitude is a great way to debrief from the many emotions of what it is to be human, and also from the presentation. So you could think of one or two things that you feel grateful for today. You can think of those who you love who are still with us and who may still be with you. And it's a perfect moment. It's a perfect moment to transition into the silver linings that I've experienced. And so we're going to see the earth right here. That's one of the biggest things we could be grateful for, is the earth that houses us. And so lastly, I'm grateful for all of you guys. I found this space without thinking what it was going to be all about. But I found a safe space for all of us. And for me, it's been an emotional support group, especially because it's founded on health education. And all the casual chat, it just livens my heart. It warms me up. And so there's silver lining in a heart shape. And it just, being together like this, it really brings out the inner light. And with this in mind, I conclude the presentation.